Hello, I'm Norman Swan. Welcome to this programme on birthing in the bush. Obstetric services in rural and remote areas are disappearing, with over 130 maternity units closing down across country Australia just in the last decade. The reduced support for rural women to have uncomplicated deliveries in their local communities has meant that these women have to travel in pursuit of antenatal care and a safe birthing experience. Some women feel so pressed to choose unnecessary medical intervention, such as induction or caesarean section, for no other reason perhaps than to minimise uncertainty, cost and disruption to their family lives. Such pressures have a major psychological and social impact, not just on the mother and her baby, but also on families and on rural communities in general. So this programme looks at a lot of things. The latest research in the care of pregnant women explores limitations of such research for rural women and their health professionals, and also the models of patient care for women with low-risk pregnancies, models of care that might enable them to give birth in local communities, and we'll be hearing about some of them tonight. In particular, we'll look at the needs of Indigenous women. And as usual, of course, there are a number of useful resources available on the Rural Health Education Foundation's website, rhef.com.au. But now let's meet our panel. Peter Bland is a staff specialist in obstetrics at Royal North Shore Hospital in Sydney. He's involved heavily in education and training of students and medical officers. He's at Sydney University and the University of New South Wales and the training supervisor for the College of Obstetrics and Gynecology. And prior to this, he worked in Port Macquarie, in public and private practice. Welcome, Peter.
Thank you, Dawn.
Sue Kildea is Associate Professor of Midwifery at Charles Darwin University in the Northern Territory and Vice President of CRANA, the Remote Area Nurses Association. Sue's a registered nurse midwife with extensive experience in rural and remote Australia. She's worked as a nurse practitioner in remote Northern Territory in Queensland and in regional support roles with the Flying Doctors in the Kimberley, and also as a women's health educator in the Top End. Welcome, Sue.
Thanks very much, Norman.
Surprised you got the time to be here, but we're very grateful for it. Sue Dunning is a team midwife at Southern Flinders Health Crystalbrook in South Australia, and we're going to hear, Sue, about your project later, which is a new model of care.
Yes.
Which has a very strong midwife stream.
Yes.
And last but not least is Dr. Tracey Patti, who's a general practitioner and has been in private practice in Bow Desert, Queensland since 1985. And you've recently not given up, essentially, GP obstetrics.
Yes, I've given it up for a little while now. But
it gave you up, or did you give it up?
It was a combination of both, but basically I gave it up when the unit was not staffed properly, and I was the last private practitioner delivering in that hospital.
So that's a common story with the closures, is it's not necessarily a shortage of budget, it's a shortage of people to actually staff it.
It's a shortage of people, that's right.
So in Bow Desert there's no obstetric service now?
None at all, no.
Do you do antenatal shared care?
We do antenatal shared care, yes, but we don't do any deliveries at the moment. We're always ever hopeful, but...
Sue, what is the scene when you look over the country?
Well, I think you've mentioned it yourself, Norman. We're seeing closure of small units that is just... I think we dropped the ball on this a while ago. We didn't anticipate what was going to happen. We didn't realise that just one after the other small units have closed down across rural and remote Australia. And we've still got, 30% of the population living out in sort of remote areas, rural and remote areas, and yet we don't have the birthing services for them.
So Peter, just to explain this draft to us, this is where people live who give birth.
I think we're describing there where people actually live rather than where they actually gave birth. It probably correlates fairly closely, but specifically the question asked by that graph is different from where they actually delivered. But generally speaking, it represents that around 30% of babies in Australia are born outside major cities. That's probably the summary of it.
And Sue, are you seeing the increase in your area that we're seeing around the country with the baby incentives that have been handed out? People are seeing a large growth in births.
There seems to be an increase in numbers in rural areas, women birthing.
And has that been hard to deal with? I mean, there's some major maternity hospitals around the country that are finding it hard enough.
It is hard when you haven't got the staff to staff the hospitals for the maternity units. Yeah. So you need to look at other avenues.
Christine, you've seen the increase in your community too?
Yes. We've it's a high growth area where I live, and there's been a considerable number. In fact, we were delivering about 420 babies at Bow Desert when it closed.
Really?
And now we estimate there's about 600 go off to Logan.
That's a lot.
It is a lot.
What's been the impact of it going off of women going off to Logan? I mean, people talk about people quietly having the baby at home by themselves, higher rates of intervention for convenience because they've got to travel a long way. What's your impression from your patients as a GP?
Well, we have a few more born along the way from Beaudesert to Logan. It can take an hour to get there.
So they're delivering in the car?
Delivering in the car. But there's also a lot more planning and a lot more induced deliveries because of circumstances of trying to have the husband there and having transport to hospital, and a big increase in people who are electing to go privately because they can have those inductions and caesareans more easily.
So in other words, they're travelling to Brisbane or Logan to actually have a planned delivery?
To have a planned delivery, yes.
So that they can work around?
Yeah.
Are you finding that in South Australia?
Not so much in our area. There are definitely planned inductions because of people who live sort of 4 hours away and they need to have the baby while the husband's off work. And so, yes, there are those planned inductions, but it's not wide.
Sue, the other Sue there, very confusing. We should really have our panels better planned than this. That's right. We can all call ourselves Sue and just get on with it. Are there poorer results in the rural areas? And we often say rural health is poorer than metropolitan, but sometimes that's actually more rhetoric than true. In terms of obstetrics, are there poorer results corrected, for example, for the Indigenous communities?
Well, there are. We know that for most of the indicators, the Aboriginal and Torres Strait Islander women and families have 2 to 3 times, say if you're talking about low birth weight, it's sort of double 2 to 3 times. If you're talking about perinatal mortality, maternal mortality is certainly higher, and the problems are worse in rural and remote areas where, of course, the services are less. So we do have that, and I think it's really interesting talking about people, planned inductions, planned caesars, things like that. The other thing that we haven't taken a lot into account is the shifting of costs, because the costs are now going back onto the individual family, individual women, and that's, I think, another thing that needs to be taken into account.
So we've got a question from Marcel George, and from Western Australia, in fact. And the question is, are there any home birthing services specifically for Aboriginal women?
Home birthing specifically? Not home birthing, no.
Not home birthing. So and you would say no?
No.
Right. 0. So let's see the answer to the question about where you practice, metro, rural, remote, etc. Let's have a look at the answers to that question. Oh no, this is the birthing in the bush question that we're getting the answer to here. So this feels like election night, really, doesn't it?
Are we winning?
So about a quarter of you think 1 to 50, a quarter of you think 50 to 100, a small number think over 100, and 40% of you, 1 in 10 think there's no minimum, and an honest 30% haven't got a clue. I'll come back to the first question in a minute. What's the safe number?
I'd probably go with the ignorance of the 31% that didn't know, and I think that's probably what we know. I don't think evidentially we can actually say that there's an evidence to say that there's an exactly safe number.
So this is for a service we're talking about? For
a service to provide. I don't know that you can actually say there is a safe number that's required to provide a service at a particular unit to come up with those numbers.
But surely there must be a safe number for a midwife or a doctor.
For an individual to perform, again, it would be nice, and there are certainly numbers that are put out from the medical point of view and from the midwifery point of view of around 20 deliveries per annum is okay, but that is very much, that's a number picked out of the sky rather than a number based on evidence. And I think it probably is variable because, of course, it varies dramatically with the experience of the individual you're talking about. So if we talk about somebody with a wealth of experience, to maintain at 20 is fine, but someone with minimal experience to work with 20 as their first year out is perhaps not what's required. They need perhaps more.
So just to summarise then, the impact of closures are, you believe, roadside deliveries, inconvenience, perhaps a bit more intervention in that group of people than required. Anything else, Sue, from your... Sorry?
Expense to...
And the expense.
Yeah.
What
hidden
about
expenses are important. I think what Sue says is very important. It's a hidden expense because a lot of cost shifting goes on, and money which was originally therefore spent as public money with the government is actually now shifted to a family who's actually paying a lot of these bills instead of the government.
Right.
So they may not be picked up on a budgetary assessment so much as families are actually paying a lot of their own personal cash to get things done.
Right. What about Indigenous communities? Are the closures affecting them, Sue?
Well, I think this is where it happened first. I mean, if you look at remote Australia, this is where we first saw the closure of birthing services, and that women have been moved sort of at 36, 37, 38 weeks, depending on where you are, and it's not the same across the country, but they've been moved to the regional centres to wait birth, and that's been the case for probably longer than it is in the rural areas. It's now starting to happen not only in remote, it's happening in rural areas with the closure of units, and it's starting to impact on more and more people, and we're sort of now at the state where we're going, well, hang on, this isn't actually is this a good thing? What's going on? How can we stop it? How can we prevent it? How can we turn it around?
We've actually got a short video of an elder woman talking from Nhulunbuy in Northern Territory. Just to explain the story here behind this little grab we're about to play.
Well, one of our units, Gove, it's Gove District Hospital. It's a maternity unit that services lots of small remote communities. It's it's a great unit. They've got the best outcomes in the Northern Territory, and in March, the end of March, it's about to have its maternity services closed. So 131, it'll be the 131st perhaps. I'm not sure if if those numbers are right, but yeah, it's about to be closed because they're losing their GP obstetrician, and they at this stage they see no other way of doing things. So the unit is about to be closed. The Yolngu women from Arnhem Land have said that they've sent down a tape and sent down a message and asked us to play it.
And here it is.
Where the hospital sits is situated on an ancient historic ceremonial ground, and that's the very purpose why this facility is so special towards the Indigenous people of Arnhem Land. This facility also practices the ancient healing, which my department, Strong Women, Strong Baby, Strong Culture, is requested by the maternity board to carry on a smoking ceremony after birth for both the mother and child. Now, anywhere else in Australia, you wouldn't find this. Nowhere else that I can think of. That's why strong women here feel that this service needs to continue in this particular region and nowhere else.
That's an elder Yolngu woman speaking about the uniqueness of that service, and and that's really quite important. And that it's blown up in places like Alice Springs over the years, but that specificity of service to suit the cultural needs of a community it is unique wherever it happens.
Absolutely. I mean, women have been telling us that the services that we're providing for them are not culturally safe. They don't feel culturally safe in our services. A lot of our services, not all of our services, and we're not listening to them. We're not very good at listening to Aboriginal women and changing our services to meet their needs. And they believe they know some of the answers that will actually make a difference and help close the gap. It's time we listened to them and actually changed our services so that we could actually try and make a difference.
But of course the bottom line in this community is the same problem as there was in Bow Desert, which is staffing and workforce. So here's, before we go to the next question, let me just give you the results of my aborted question, which, so where are you located? Metropolitan, regional, rural, so here are the answers. A third of you are from metropolitan, you interlopers. You've got to move to the country straight away. Regional, about 1 in 5, and nearly half in rural and 5% in remote. So an interesting split there. Our metropolitan viewers on webcast are taking advantage, no doubt, of greater broadband access, I would suspect. You're most welcome, and stay with us. we've got another question here from North Queensland, from Marissa Pillar, one of our satellite broadcast viewers. It's becoming common in my area for pregnant women who go overnight with labour or who will be induced to give them a temazepam, 10 milligrams at night. I have concerns about this practice. Is it safe for the mother and baby? Peter?
It's making use of a medication to sedate a woman before she has her baby. It is using a medication which is certainly not natural. And I think in the ideal world one would avoid medications which were not necessary in pregnancy, and that would be the stock standard answer. In the world of pragmatism, if a woman is trying to get some sleep the night before her baby's born and she's in a busy hospital, then that might make her get a better night's sleep in preparation for the labour. So I can understand the pragmatic nature of that solution, but I would think that it's not best medical practice, certainly.
And it's not a tocolytic, it doesn't stop
It's not
labour.
a tocolytic, it won't change the labour at all, no.
A couple of comments and questions here. One's from Duncan McKinnon, I think it is. I think the end's looking at R, so it's Duncan McKinnon, I'll say. And the comment is that in the UK, units are closed if they deliver fewer than 1,000 births.
I think the message there is that the UK is a different country from Australia, and certainly they do run with specific numbers in the UK. Their solutions and their answers probably aren't really applicable to this country. We're a bigger country and a much more dispersed country in terms of population, and I don't think we have the luxury of doing what's done in the UK here, and therefore to extrapolate their management is probably not really logical.
And another question from Jennifer Brown from the Northern Territory Clinical School. Do the patient travel systems cater for families needing to travel for their birth?
Well, of course they don't. Unfortunately, I mean, it's a Commonwealth funded Patt system, but it's got local administration in different states and territories. But no, they don't cater at all for the families. So you've got women leaving their children behind, you've got partners that don't necessarily get included in the travel, you've got women that, I was reading a report about, actually it's titled Lucky We Had a Torch, and it was, a birth by the side of the road, but women there in Western New South Wales, they're travelling on average 4 to 5 hours round trip for an antenatal visit, 7 to 8 hours round trip for the birth, and they're not getting that reimbursed. The paperwork that goes with PATs is just so hard and so complicated that they're not even getting that reimbursed. So it absolutely doesn't cater to the families. Let's
ask you another question, because we're going to start talking about the workforce issues. How far away is your nearest obstetrician? Inside, within 50 kilometres, within 100 kilometres, within 500 kilometres, or over 500 kilometres? So answer those questions and we'll come back to that. So with the under 50 kilometres is local. I'm sure that's for a rural.
Relatively local.
Yeah, that's right, yes.
A suburb away.
But workforce, Peter, is a huge issue because we've already alluded to it several times already in this programme. Yep. What are the key issues here? Because it's recruitment and retention.
Recruitment and retention are the two issues. I think if we look at the personnel that are in place at the moment, on a review which I was involved with a couple of years ago, we assessed in New South Wales, in fact in Australia, the type of people who were, in terms of medical people who were delivering babies, they tended to be male, they tended to be about 55 on average age at that stage, and they were planning on leaving in about 5 years was the general principle, and that was about 4 or 5 years ago, so many of these people may have already left. They have as that type of person, there are not a lot of people as a cohort rushing to replace these people when they go, and unfortunately, although there have been attempts made through the training of younger specialists and certainly general practitioners to go to the country, we've done this by encouraging them to have some of their training in the country, so this is actually an idea which has been around for about a decade now.
And what, ACRIM has not had an impact because they've had a huge push to training procedural GPs. That's not flowing through to the system?
Well, it doesn't seem to be, does it, Chris?
No, it doesn't seem to be so far. I mean, we're hopeful that eventually it will, but currently we're certainly not seeing.
I think one of the problems about, again, to go to statistics, is that we actually produce the people in terms of the qualification, but they don't necessarily end up where we wish them to end up. So that although on paper the numbers are created, we still produce more obstetricians, for example, than ever before. They tend to be the type that they either practice gynaecology or they practice in the city, where they can make a much better living, and the disparity between income of the city and the country continues to grow rather than be chased by at any stage. So there's a huge financial incentive to end up in the city. We've also got
is there really? I mean, the impression is that specialists in the country do quite well.
No, not compared to their city counterpart. And so yes, they do a good income, and having worked in the country for 17 years, I'm not complaining about my income, but certainly there's a major disparity between city and country. The other factor we've got is we're training older doctors, because we now use a lot of the medical courses, half the medical courses in Australia are now postgraduate, with the result that our doctors are a little bit older when they come out. They've started their families, and rather than therefore go as a single or even as a new couple to the country to start their work, they're coming out as a couple with a couple of children, and they want to stay close to where their supporters are in terms of family. So these are all factors in terms of the workforce.
Christine, do you agree in terms of the
yeah, I agree entirely with Peter there. And the other problem is keeping them there. If there's no opportunity for spouse employment or schooling for the children, then people are not going to stay, or they're going to get to stay a short time, and then as soon as an employment opportunity comes for the spouse somewhere else, they'll head off.
But there is locum relief. There are some specialist
locum
systems.
relief was developed a couple of years ago in conjunction with the federal government, I believe, where it was suggested by a couple of provincial chaps got together to put a plan together whereby the government would subsidise locum services in the country for specialists, and I believe also for general practitioners, to have a locum service provided where the government shared the cost of the locum to encourage covering that particular aspect of the provincial doctor's care. I think one of the other factors which has changed my own experience as a person who worked in the country, 30 years ago, people who went to the country forever. And I think that's changed, where the whole generation of occupations in our society has changed, where people tend to do a job for 10 or 15 years and move on. And I've done that myself, and part of that was for education for my children, but I know at least a dozen other similar doctors of my own standing who've now gone back to the city in the latter stages of their career. And that's a draining of the country services as well, because we actually put people there and then we lose them afterwards, which makes it worse.
So let's look at the results in terms of where your nearest, how far away your nearest obstetrician is. So 70% it's nearby by rural standards, and the rest fairly evenly spread. But there's a
30% of the population we're talking to tonight are in the city. Or was that not correct?
Right enough.
We're metropolitan.
That's
in which
true.
case that's going to skew your figures.
Yeah, so let's say it's 30%, but still, even so you could deduct the 30% from that. It would still be the majority is within a reasonable distance, but there's a fair spread, that 15, 8, 23, 26, so a third. It's quite a long way away for the third of the people there. Midwives, Sudani, the issues are quite similar, aren't they? An aging
quite
workforce.
Similar. Aging workforce, recruitment out into the rural areas is difficult, and remote areas is almost nil, I think, to get midwives. And
does the opportunity for independent midwife practice raise itself? Is it an issue? Is it an attraction to keeping people?
To practice midwives, to practice midwifery is an incentive for midwives.
So, well, I've got a couple of questions here. Sorry to interrupt. Maybe it helps to answer the question. One is from Karen Kennedy at Gosford Hospital. What's the opportunity for Bachelor of Midwifery students to work in rural areas coming out as a new graduate? Sue?
Fabulous question. It is, because I don't think we've actually...
Did you seek this question, did you?
No, I didn't.
No,
it's a great question, because in the past we've always thought that you have to be a nurse and a midwife to work in rural and remote areas, and that there's no place for people that are midwives only. But I actually dispute that, and I think that if we actually... This is a workforce that is being trained at the moment. It's cheaper to train midwives than it is to train nurse midwives. We're mad if we don't accept them into rural and remote areas, and I say open the doors and let them come. I think probably as they come, they will come to the places that start introducing different models of care, and that will actually help some of the rural and remote areas.
And in a moment we are actually going to talk about alternate models of care. It's one of the main points of this programme, is actually to give you an opportunity to hear about how people are actually trying to do it, so that in your community you can start to, or continue to, or maybe restart offering the ability for safe, low-risk deliveries. Another question, just while we're talking about midwives, is from Rachel Morgan, a midwifery unit manager in the country area. Can we stop rural hospitals from requiring midwives to work as registered nurses? Sue Dunning?
I don't think you can, no.
If they're not trained as registered nurses, they can't work, and perhaps that's one of the advantages of having pure midwives rather than...
Well, it's one of the problems, isn't it? We've got midwives out there, but they're spending more than 50% of their time working as nurses rather than midwives. And I think it goes hand in hand with changing the models of care. So if you change the models of care, you enable the midwives to work as midwives 100% of the time rather than 10, 20, 50% of the time, you'll get better use out of the workforce. So I wouldn't say that you have to stop them, but I think certainly we need to be smarter about how we use the remote workforce, the workforce across Australia. We must get smarter about it because we know the challenges that are ahead.
So is that a factor in retention, that if you're trained as a midwife, you're allowed to actually practice as a midwife?
Yes, because there are midwives that's all they want to do. But there's also registered nurse midwives who prefer to work across the whole spectrum. And so, you know... So
the usual stuff, one size doesn't fit all.
That's right. And that's what needs to, you know, people need to be able to make choices about how they work.
I just want to ask a question about general practice. If we could just go up to that question there. Can GP obstetricians, and I might ask you, Christine, you might know the answer, can GP obstetricians in rural areas be allowed to relinquish general on-call duties?
Well, that's a very interesting question. I think ideally it'd be great if you didn't have to do general on-call, and if you were a GP obstetrician it might give you a bit more time. But in reality there's usually only 1 or 2 practitioners, especially in the remote areas, and you've got to have on-call. I think it's a...
Having said that, if you can make that sort of stuff work, these are the concepts of local plans, and that may work for where this question came from.
I'm not sure where that came from.
They may have the numbers to support that, and these are the sort of creative things which are not going to increase costings, they're not going to change the balance of payments and things, and they may be quite receptive in an administrative role to accept that, because it might make the job more attractive for the obstetrician or their GP obstetrician to cover that role because he's getting a reward or she's getting a reward for not doing the other stuff. And that's the creativity, I think, that Sue keeps referring to, that we've got to have some thinking outside the square, some new plans that are going to work. So that's a good option to do.
I think you're right. I think it is a good option. It's just, if you've got a big enough service, yes, it'll work. But if you're Johnny on the spot, it's just not going to work. Sure. But so it would be ideal.
Just a comment from Pambula, from Janet Watterson, who's a GP there. We have 4 GP obstetricians, but they still close the hospital maternity unit. So they are. Well, they can go and work in Bow Desert or Northern Territory.
Welcome to the Northern Territory.
That's right, loads of work for you there. And another question here, which is most deliveries are uncomplicated and therefore currency isn't critical. Currency for midwives is a different question from currency for medical practitioners who carry the can at the end of the day. We can accept small numbers of deliveries under 150 if we're prepared to accept the risk at the end of the day. So is that a fair comment, do you think?
I'm not so sure that's a fair comment. It's a fairly loaded question, isn't it? We're prepared to accept this if we're prepared to accept the risk at the end of the day, but I'd like to know what that's being based on. I mean, the evidence that we've got at the moment to date in Australia shows us that small units are safe. Internationally, we've got evidence that actually shows us that very small units are safe with very good outcomes. So the risk at the end of the day, I mean, what are they saying?
The question is, well, I'm actually putting a proposition to you. Midwifery care models offer the best alternative in rural areas, and partly that's what Katie was talking about a moment ago. Yes, no, maybe. And we'll get the answers to that in a moment. Sudani, tell us about your model of care. It sounds very similar to Katie's.
It's very similar to Katie's, yes. We started the model because we were having issues with numbers of midwives to provide a service, and so we got together with the GP obstetricians, and in the end we work a model now with 5 midwives and 3 streams of care, where there's the medical model, a shared care model with the GP, and a midwifery care model where the midwives see the women mainly.
Does the GP see them at all?
The GP sees them 3 times during the pregnancy.
And who does the delivery?
The midwife.
So it's end to end?
Yep. And we look after them postnatally to 6 weeks.
And is that risk managed? How does that...
Yes, we have a pregnancy management plan that we follow, and that is run with the ACMA guidelines for consultation and referral, and so we follow those guides.
So you got the 3, and the woman chooses which one she goes through?
The women choose their GP, and then if they're low risk, they can come into the midwifery lead.
But it's their choice?
Their choice.
And what are they told about the 3? What's the informed consent, if you like?
We've made a flyer and they get the information, and it's their choice.
And when you're in the midwifery one, you know who your midwife is, and
yes,
she's the,
yes,
or he
it's
is
a
the
named
person.
midwife, and that midwife follows you through the whole pregnancy.
And that doesn't happen in the first 2 models?
Yes, we do. We in Crystalbrook, because the midwifery team provide all the maternity care, all the midwifery care. They're not on staff in the hospital itself, and so the women have a named midwife that is responsible for them.
Was there much resistance to the hospital not having the people, the nurses?
No resistance at all, because to maintain the service, this is how we.
So when you said you had
service going,
you're doing this with fewer midwives than you had before. What's the story? I'm not quite sure what the workforce.
The workforce, really, you should have if you're going to provide a maternity service, you should have a midwife on each shift. So that's 3 midwives in 24 hours.
Plus holidays.
Plus holidays and sick leave, etc. So I think at that point, Crystalbrook had 4 midwives, and they couldn't cover 24/7 on shifts, and so they were using agency staff. The midwives that were there were working a lot of call on top of their rostered shifts.
So quietly, that's quite radical. So instead of staffing the hospital, you're staffing the patients.
That's right. Yep.
So the staff follow the patients.
Yes. Yes. We provide a 24/7 call roster, and we work 12 hours. Then hand over to the next midwife if necessary. But yeah.
But essentially, you're on 24/7 call for your woman.
No, you have days off.
You do have days off?
Yeah, there's days off.
Right, so you're not necessarily delivered by the midwife who follows you through?
We've had a 91% of our women, not 91, 71% of our women have birthed with their named midwife.
Not bad.
Yeah, we think that's good.
And what are your critical success factors? What do you measure, how do you measure success?
By the women. The women love it.
Do they?
Yes.
So you're seeing a drift towards midwifery care then?
Yes, yes. It's about a third each stream, but it was the midwifery stream was slow to start, but now, yep, we're.
And what about complications, perinatal problems, that sort of thing?
We talk with the GP obstetricians, of course. We have meetings with them. We discuss with them if there's any problems, and of course, refer to them if they need further medical.
So the role of the doctors is more as a consultant in
Yes.
many ways.
Yes.
In that
Yes.
situation, they're there as backup.
Yep.
And it takes a bit of the heat off them. And what about intervention rates, inductions, episiotomies, that sort of stuff?
Don't do episiotomies. Inductions, there hasn't been much of a change with inductions because of the reason women come to the area and their husbands are only home for 4 days, and so they need the timed induction. We have found a reduced rate of pain relief, so less epidurals, more natural labours, an increase in breastfeeding rates, which has been good.
Fantastic, we all want one.
Yeah.
So
and reduced length of stay in
So
hospital.
Port Pirie, which is also in your area, has
That's
got what models of care has it got?
Well, basically we run the Stream C model in Port Pirie alongside the medical model with obstetricians. And
so Port Pirie's got specialist obstetricians?
Yes, we've got specialist obstetricians, and we offer the women an option. So if they're low risk and would prefer midwife-led care, well then they come to the midwives.
And what... And the obstetricians are as happy as the GPs about this, are they? Loaded question, you've got to go back and work with these people.
Loaded question, yes, that's right. It was a bit slower in Port Pirie because the service wasn't threatened, and it is just, it's an option for women to have midwives.
So it's less of an imperative.
Yeah, that's right.
And so what would you say are the strengths and the weaknesses of the different models, if you were to be as honest as possible?
If you're going to lose your service, working together, the medical fraternity and the midwifery fraternity working together, you will work together and sustain your service.
But that's what it takes to work together,
That's
does
right.
it? That threat.
That
That's
threat.
pathetic.
It is.
Oh, crikey.
What's the biggest barrier you face to keep it going? I mean, is it this issue of midwives being put
It's
in
still
the nursing
recruitment
roster?
and retention, and it's about midwives doing midwifery.
It's about midwives actually being able to do midwifery, and in a lot of places they haven't been able to, and we know from the research around Australia that that's one of the reasons that they leave the job. They leave midwifery because we train them to do things and then they're not allowed to do them. They go and work in a place where they can't be a midwife.
So let's see what you thought of the maternity models of care and get the answers to that question in. So you 71% thought yes.
Oh, wow.
That's before we even explained what it was. 25% are not sure and 3% are emphatically not.
I think we need to check who we're talking to here.
Well, we should
have asked
we should have asked that question. It's a bit late to put it into the system. Next time.
Midwives versus medical officers.
So here's a question. In fact, I was going to ask it, but Sabina Knight from the Remote Area Nurses Association has asked it, which is to you, Sue. What are the critical elements or foundations essential for remote maternity care?
Thanks, Sabina. I think the critical elements for remote care, I'd like to see skilled providers out in remote care so that women are getting care by midwives in places where there's not local midwives. Let's send them out. Let's do the outreach midwifery. And I think we have to work side by side with, if we're talking about Aboriginal communities, side by side with Aboriginal women. It might be the strong women workers, it might be the Aboriginal health workers. If we don't work side by side with them, then we're not going to know or understand the community, and our care is not going to be as good as it could be. So that's got to be one of the most critical factors.
Have any of the medical or nursing bodies, this is from Sandra Bell, also from Crana, have any of the medical and nursing bodies looked into the reasons that remote centres with a midwife and appropriate equipment are still required to encourage women to leave the remote community by 36 weeks? This is the situation, she believes, in Western Australia.
Well, it's interesting, isn't it? Because we've got different rules across every state and territory. Some people leave at 36 weeks, some at 37, some at 38. I think what we have to do in Australia now is we actually have to have the debate around what are the most appropriate services in rural and remote areas. We haven't had it. We haven't talked about birthing in primary units. That's units without 24/7 access to caesarean section, and that's what we need to actually start looking at. What do we consider safe? At the moment, as soon as we don't have access to a theatre, we close the doors and say, well, we can't operate here. But I think actually we need to look at other countries around the world, Canada, Scotland and New Zealand, that have got primary units where they're operating, you know, it might be an hour, 2 hours, 3 hours away from a tertiary centre, and their statistics that are starting to come out now are looking good.
A question for you, Sue, from Janet Watterson, general practitioner. How many deliveries at Crystal Brook each year?
50 to 70. It was 50, but it's climbed to 70.
And Port Pirie?
180 to 200.
And another question from Janet is, does Crystal Brook have midwives available 24/7 for postnatal stays if it's not a normal roster?
We provide postnatal care and set up care plans for the registered nurses to follow that we supervise.
Right.
And they call us if there's any problems.
Right. So if there's a postpartum hemorrhage or something like that, they would. That's why. I mean, so if there was a postpartum hemorrhage, would they call you or the GP?
Well, GP.
So
and us. And they would call both.
Both together.
Yep.
A comment from Rachel Morgan is midwives are very unsure about changing the model of care from the standard rotating rosters within the hospital walls to caseload midwifery. Is that common experience? Just a little bit?
Yeah. I mean, it is. And I think we were talking earlier and saying that, you know, where we've seen innovative models get set up, there's often somebody there to help. So there might be a project officer for a while, there might be a change agent, there might be a visionary leader, as Peter was saying, but there's somebody there to actually help look at, you know, what are the guidelines, what are the protocols, how are we going to do it, how's it going to work for everyone, and do it like that, because a lot of the midwives have never worked like this. So for them it's different. It's how they were trained, but not necessarily, well, how they were trained in
the clinical
theory,
not
but
the
not
structure.
That's right.
Yeah.
And a comment from Duncan McKinnon, a general practitioner, pardon me, who sounds as if he was UK trained. I would love a midwife-led service, but my medical colleagues are uncomfortable letting go of the Australian model of doctor-controlled deliveries. In the UK, doctors are by and large never required at normal deliveries. It's midwife delivered. So is it a cultural thing then in Australia?
Very much a cultural thing, and having worked in the UK myself for 18 months, it's a different kettle of fish. Their role of the midwife is quite different, the role of the doctor is quite different in the UK.
So I'm going to ask you the question again, just to see whether or not we've converted any of the maybes. So midwifery models of care offer the best alternatives in rural areas? Yes, no, or maybe? See whether or not any of the undecided have moved over. Might as well try for a landslide and move on. What do you consider, Christine, to be the standard of antenatal care if you're talking about rural, remote Australia?
I think it shouldn't matter where you live, rural, remote, anywhere in Australia. The standard of care should be the same for all. Everyone should have access to the best quality care there is. That's not always achieved, but I think ideally everybody should have the same access, or at least the same opportunity.
I think if you don't start off with that as your premise, then we've already lost the battle.
Yeah.
I think that you need to have that as your basic raison d'etre, is that we're here to actually provide all women in Australia with the same good quality care as we possibly can, and to compromise at the beginning in your mission statement means you're never going to achieve anything like it.
So what do you do, for example? Well, you're lucky in a sense, you're not that far away from a major centre, but
right.
Let's say a woman who qualifies as gestational diabetes. Would you handle that yourself in general practice, or would you refer it on?
Depends on the model, I guess, whether they're a shared care patient or whether they're choosing to have most of our care, or whether I'm sharing with an obstetrician that comes to town. But generally I would do most of the testing and I would refer to the dietitian and then get the patient to go to the next hospital appointment that I could get for them to be followed up to see whether they were going to involve an endocrinologist or not. But generally I would handle most of it myself.
And hypertension in pregnancy?
I would handle the basics of it, but I would refer on.
Right.
But I have the luxury of being able to access somebody, you know, not too far away. But yeah.
I mean, the question is, do you think, I mean, the more remote you get, because a fair percentage of our audience are living quite a way away from the nearest specialist care, do you think that you can manage gestational diabetes, hypertension in pregnancy by yourself in general practice?
I think it's an individual situation again, and ironically I'm currently working in a teaching unit where I'm training registrars, and they actually have to work in provincial units as part of their training, and they claim that they get better training in managing hypertension and diabetes in a provincial unit than they do in a tertiary unit, because unfortunately every patient who gets hypertension or diabetes in a city-based hospital gets immediately referred to a hypertensivologist, or the nephrologists tend to look after a lot of that, endocrinologists look after the diabetics. So in fact our registrars are actually working virtually as midwives, doing the basic obstetrics while the medical stuff is being done by somebody else. They go to a country town, we send to Port Macquarie, and those registrars actually have to write up insulin, which they've never done before, or write up antihypertensives they've never done before, because this is done by the specialists of those firms. So I think that one would think there was a extrapolation that the small hospital was good but bad and the big hospital was good. I don't know that it's a linear relationship, and it changes, I think, across the spectrum. So perhaps some of a dedicated general practitioner with obstetric experience and good experience in diabetes and hypertension would probably do, in many cases, a better job than is being done in some of our tertiary units.
Let's get the results in, and it is in fact a landslide for the midwife model, care models. We've converted half of our maybes to definite.
Christine and I'll leave now. It's okay.
That's right.
You're part of the model.
That's right. We can't do it without you. We can't do it without you.
We absolutely can't do it without you.
And a comment from Linda Days, a midwife, saying it's important to note too that it's not just birth that's affected by minimal bush services, but things such as breastfeeding, which in turn affects long-term health outcomes. So thank you for that comment. And here's, but another issue, Christine, is which I think we can get too Pollyannish about remote communities. One of the problems is you might only have 2 GPs in town.
Yes.
Both might be committed Christians who don't believe in terminations. And there's anecdotal evidence that women are actually not offered everything in some communities, particularly if they're wanting, they're not wanting to just use their age, for example, as an indication for an amnio. They're wanting, say, the blood tests, etc., for screening to see whether or not they merit an amnio or a coron villus sample. So, do you think that is an issue? The fact that in some communities they may not be offered what would be considered best practice in a country, in a city?
I think that it can certainly be an issue in some areas. We have more and more cultural difference amongst our doctors, especially in the bush these days, and that can be quite an issue, that abortions are not offered and that the counselling isn't maybe as appropriate as it should be. But ideally, one would hope the medical practitioner could put their own prejudices or whatever you want to call it aside and offer unbiased advice, and then let the woman make her own choice about whether she aborts or doesn't, or whether she goes to another centre.
We're looking at this at the moment a little bit with screening, the tests that are offered for screening in pregnancy, and what we've discovered is, and it's early, we're doing research across the Northern Territory, but what we're finding is that it might not be that the tests aren't available, it might be that you can't get Patts, so you can't actually even get the transport to the tests. So that can be a really big problem too.
A comment from Alice Chipman, who's a student. Being a Defence Force family in Katherine in the Northern Territory, Defence caters for specialist medical journeys to Darwin, a 3-hour drive. Most obstetricians in Darwin require birthing mothers to be based in Darwin for at least 3 weeks prior to birth, which can be costly for a family. Defence offers its remote families some security with regards to specialist medical care. So, join the army. Let me ask you another question now, which is kind of in relation to the next point we're going to go on to. At what gestational age do you see women for their first visit? Under 12 weeks, 12 to 6 weeks, and 16 to 20 weeks, or over 20 weeks? So under 12 weeks, 12 to 16 weeks, 16 to 20 weeks, or over 20 weeks. And it'll be interesting to see what the answers are. And unfortunately, we won't be able to divide that up by rural and metro, but we are going to try and ask an occupational question in a moment or two as to, which grouping which silo do you belong in? Anyway, let's go into our next case study, who involves Lisa, who lives in a rural property about 5 hours drive from her nearest obstetrician. Her first antenatal visit was at 20 weeks gestation, and her first visit to the obstetrician is at 30 weeks. Any problems here, Peter? As the obstetrician seeing her at 30 weeks?
I think that we have a situation of what would be labelled by both parties here, that's the midwifery and the medical, as being a late booking patient, and that tends to confer an increased risk to the pregnancy in isolation because she misses out on some of the early opportunities for intervention, but also because that pattern of behaviour often carries with it other factors such as cigarette smoking, such as poorer lifestyle, these sort of things which compound the complications. So she would be probably considered a high-risk patient turning up with that. She may not have those other features, but they could certainly contribute.
But there is a perception out there that 20 weeks is okay, isn't there, Christine?
Well, for a long time, the first appointment you could get with an obstetrician at a hospital was at 20 weeks. Nobody saw you before 20 weeks. So I think that there's a bit of expectation that it's quite safe to wait. In the patient's mind, I mean, not in the doctor's mind.
Sometimes the reason for that might be more to do with the busyness of the booking services. It also means that you miss out on seeing pregnancies which are non-progressive, so the miscarriages don't get seen, and it saves a bit of work. And I certainly believe that at some institutions in the city where we book patients after 14 and 15 weeks, which actually foregoes the opportunity for the specialists in those hospitals to provide the counselling regarding Down syndrome risk screening, is actually taken away from these hospitals because they deliberately book them after the time when you could do the screening. So I think there's often other agendas apart from poor patients as to why they're discouraged from those early visits.
So is there any evidence that, if, let's say that the first visit's at 20 weeks, and let's imagine that she's found to be mildly hypertensive, is there any evidence that finding mild hypertension at 12 weeks and managing accordingly has a better outcome for the baby?
I don't know that there's any evidence to suggest, if it's mild hypertension we're talking about, it's probably going to change the outcome. The pathway of exactly whether it is hypertension is lost to you, because the booking blood pressure is a better indicator of what the background blood pressure would be rather than picking them up at 20 weeks. So you've got a much more clearer understanding of where the patient was to start with, because they've already been affected by the pregnancy at 20 weeks. I don't think there's a change in outcome in terms of perinatal mortality morbidity for mild hypertension discovered at those 2 gestations though. No.
And a comment from Vanessa Page, a community midwife in Fitzroy Crossing. In Fitzroy Crossing, Western Australia, I've seen it all in 1 week as a community midwife. 2 labours, a number of women with diabetes, thyrotoxicosis, frank breech at 39 weeks, pulmonary embolism, intrapartum hemorrhage, and the list goes on. There's only myself and the DMOs at the hospital who manage these extremely high-risk women. It gets a bit hairy the further away you go from the main cities.
That's right, it does.
What are the elements of cultural safety? Because it's not just for Aboriginal people or Torres Strait Islanders, it's for Greek women who don't speak English and so on. So what are we talking about here? What are the elements one has to have in place?
Well, I think you're right. It's not the same one size fits all no matter what your culture is. It doesn't matter if you're Aboriginal. It doesn't mean that this is going to work for you. But I think what we have to do is we have to work closer with communities and with women so that we make sure that their services are meeting their needs. And I think what we haven't done is we have asked quite a few people what to do, but we're not necessarily taking up their advice. So one of the things that I think makes a difference is continuity of care and continuity of carer, because then you'll get to know the woman, get to know her family, get to know what is going to work for her and what is right for her, and that will make a difference to the service you actually provide.
Just going back, Peter, to that comment from Western Australia, just before I come back to cultural security, because I'm going to ask you a question on cultural security in a moment, is that story from Fitzroy Crossing. I mean, most services would be referring, wouldn't they? They would be referring in utero or in high-risk women? I mean, or what? What are we?
One is, the best place to transfer a baby is inside the uterus, so that's the first thing to accept. But I think if you've got a frank breech, which is one of the ones referred to here, which is about to come out into the world, I don't know that's a very good thing to put on a plane from Fitzroy Crossing to Perth. So I guess, again, it's individualising the cases you've got. These are obviously some high-risk patients, and they've been well looked after by people who are capable and trained to do so, and that's terrific if we have those people around to fill those roles. The difficulty, I guess, is that they're also individuals, and although they may have successful outcomes on those individuals, statistically they may not do quite as well as if they were delivered in a different place, and that's where we keep coming back to fighting a question of statistics versus individuals, I think, is a challenge for us.
So here's the results to the question about what gestational age you see women for the first visit, remembering, of course, that a third of our audience is in metropolitan areas. 40% under 12 weeks, 30% between 12 and 16, 1 in 5 between 16 and 20, and 1 in 20 over 20 weeks. It's not too bad, but there is a trend towards late booking, which is not ideal. We'll come back to the professional split in a moment. The other question is then, having just talked about cultural security, a question for you then is, does your maternity services model include a cultural security focus? Yes, no, partially, don't know. And in a sense, really, what we're talking about here, Sue, from what I hear, is a listening, consumer-focused, essentially, health system, service, is really what you're talking about, that acknowledges the important cultural issues. So we'll come back to the answers to that question in a moment. So let's go to our next case study, which is about Emma, who's just arrived at a rural medical centre in Western Australia, 4 hours away from paediatric support. She's in labour, and on examination you find that she's 6 centimetres dilated and experiencing regular contractions 4 minutes apart. She says she's only 32 weeks pregnant. She's just moved to the area and her antenatal history is uncertain. Sue Dunning?
My first thing to do would be to reassure her and to keep everything calm, but contact the medical practitioner, the obstetrician, and who then would contact the tertiary centre and go from there.
How does it happen in remote Australia, Sue?
We transfer. We try and transfer with the babies, as Peter said, with the babies in utero. So
But
we know that
you might not be able to transfer
you might not.
if she's in labour.
Well, usually we try and stop the labour. Stop the labour and transfer is the ideal.
Prepare for the worst and hope for the best, I think.
Yes, yeah. Well,
How good are tocolytics these days? Is it still Ventolin, is it? Or?
No, well, in some parts of Australia it is. I think currently nifedipine probably gets, which is a beta channel blocker, gets the main Guernsey and is the recommended option at the moment. But the beta mimetics such as Ventolin and Ritodrine in other parts of Australia are still being used. The efficacy is that they are not very good at stopping women having babies earlier in the long term, but for the capacity of transfer, it's certainly recommended to make use of some sort of tocolytic to allow transfer and allow the administration of steroids to the babe. So they're still being used widely, and particularly in the provincial, remote, rural, all those sort of areas. Theirs have got a valuable role. But
that's what you would do, and you would actually give steroids to this woman, would you not?
This woman would be given steroids, would be given tocolytics, and transfer would be arranged. But the reality is that it's 6 centimetres, and I don't know if we've mentioned whether she's her first or second pregnancy, but at 6 centimetres there would be a fair degree of angst that she may well deliver before she gets out of town. So obviously prepare for the worst, prepare for the worst but hope for the best if you could.
A question here from Katie Hargreaves, Royal Flying Doctors Service. Could you please discuss the value of the fetal fibronectin test? I've never heard of it.
Lucky I have. We did actually get a bit of a discussion. Fetal fibronectin is basically a swab taken from the cervix. A woman who'd suspected in preterm labour with a speculum to display the cervix, and then a swab taken. It picks up some glycoprotein, we decided at dinner tonight, which is secreted from the membranes, in fact, to indicate that a labour is likely or is possibly going to proceed. It's a precursor for the development of labour.
How specific or sensitive?
Well, the good part is, which I hate the word specific and sensitive because I always get them confused. So what I would say is, if the test, I'm coming back, okay. If it's positive, if the test comes back positive, it doesn't really tell you much. But if it comes back negative, it has about a 90+% chance of not delivering in the next 7 days. So a negative test is very valuable in the country situation because you spend $100 on the test, which is the cost of it, to save a $3,000–4,000, and in terms of cost, but also obviously the social implications of transporting a patient who's not likely to deliver anyway.
But a positive test is not a reason to poop your pants.
Is not a reason to poop your pants, exactly, but it is a reason to perhaps then say, well, it's worthwhile justifying the transfer.
So let's see what professional groups you actually belong to. Let's get the results here. So midwives, so 60% are midwives. Good on you. General practitioners are about 20%, but half and half split between proceduralists and non-proceduralists. And about 7.5% of you are obstetricians, and 15–16% of you are registered nurses. So interesting split, and certainly a primary healthcare focus, which is what we're on about on our rural health broadcast. So that's certainly an interesting response. A question here from Marie McLaughlin, which is, what's the largest difference when it comes to Aboriginal and Western births and non-Aboriginal births?
The largest difference in respect to, I'm not sure.
Method, or is that? Or
could we have a clarification of the question?
So, Marie, have another go at that question.
Friend, perhaps?
So that's right. And we'll come back to this. The next case study asks the question from the point of view that you are the only midwife on call, and since there's sort of 60-odd% of you out there, and there's lots of you to actually decide. It's 4 a.m. in a remote community, and Janet, a 22-year-old Indigenous woman, has just had a normal birth of her first baby, weighing 3,200 grams, so really good birth weight. She was at 37.5 weeks gestation, full-term pregnancy, and had a normal pregnancy. Following the birth, though, she starts to bleed. The fundus responds well to rubbing, but every time you stop rubbing, she recommences bleeding. Sudani, what are you going to do about this lady?
Keep rubbing.
Keep rubbing?
Keep rubbing. And get the baby breastfeeding. And contact your medical
Right.
backup.
And reassure.
And reassure. Definitely reassure.
Sue came out with reassure before, and I think reassure is really
Yeah.
important. This is a scary environment,
Yep.
and I think for the woman going through this, this is a really scary time, particularly whether you're Indigenous, you're 22 or
Well,
whatever.
hold on a second, it's a really scary situation. How are you going to reassure
Not
her?
for me, because I then tell them the truth that we can manage it. But I think that it's really important to, and I'm sure that's what you were doing, it certainly
right.
was what you went to as your first port of call with our preterm girl.
That's right.
And I think that the situation here is that you just got to reassure. It's really important.
Yep. And
And rub up the fundus.
Rub
and
up
do
the
the other,
fundus.
and do the other thing.
breastfeed.
And so, what are the statistics here of this resolving? I mean, there could be retained products, so she might need a D&C.
That's right.
So, can you make an educated guess
The
as to?
statistics are good. No, we're actually very good at managing
Acute postpartum hemorrhage.
postpartum hemorrhage. And we can usually manage, and we can often stabilise and transfer. So of course it's scary, but it's important to reassure, and it's important to for all of us to realise that we actually can, when it's managed, it can be managed well.
And there are cases, as you described, which may need surgical intervention, but the majority of cases will respond very well to the techniques that all across the profession, midwife, doctor, medical student,
So
God forbid, have all learned.
bring out your bag of tricks.
Yes.
Yeah. And that's another thing, is that we don't necessarily have all our tricks out in rural and remote areas. I mean, there's a drug like, or in the city areas, yeah. So drugs like misoprostol, it works very well. It's cheap. It's got a long shelf life. It's easy to administer. Yet you won't see it in most rural and remote areas. So I mean, I think that's something that we
Politics rather than anything else would be a fair comment, wouldn't it?
It probably
the
would.
acceptability. It's a drug which has been widely used in some parts of a lot of parts of the world and researched, and also is used in some hospitals in Australia, but at the hospital which I currently work, we can't use this because it's not accepted by our pharmacy, despite the fact the medication is listed by the Department of Health in New South Wales as a medication to be used for postpartum hemorrhage. So I think the politics become very frustrating for the frontline workers when you know there are good things there that we're not allowed to use.
Pathetic.
Yeah, that's another word for it.
So let's just get to the results to the cultural security question. We asked you, does your maternity services model include a cultural security focus? A quarter of you say yes, 1 in 5 of you say no, a third of you partially, I wonder how partially, and 21% don't know. So there's a job of work there to be done, I suspect, lying behind those questions. So a question or comment from Perry, or question from Perry Medley, who's a community midwife. Are any other town communities finding that delivering mothers are turning up to the local hospitals in labour for ambulance transfer to the delivering hospital? This happens in our town as there are a lot of families with no other means of transport.
That's right.
Yes, but it's a cost-shifting exercise, obviously, because somebody else is picking up the tab, and this is not solving a problem, it's simply shifting the focus of the problem to somebody else.
Question from Sue Krusk, who's a midwife, I think in Darwin, from the look of the email address. How should maternity services be structured to better meet the needs of Indigenous women and families? It's actually from Dr. Suzanne Belton in the Northern Territory. Just a quick question with a small answer.
Just a quick question.
And I'll give you 5 seconds to answer it.
PhD.
Thank you, Suzanne, for that simple question.
Well, I think that what we need, I think one of the things we need to do is we need to provide care closer to home. We need to provide it in partnership with Aboriginal women and Aboriginal communities. In the rural and remote areas, women have asked for a long time. They want to try birthing out on their communities again. We need to try it. We've consulted to death, and the last thing I heard was that all this consulting is insulting. Why don't you do what we say? So it's time to actually trial birthing in rural and remote areas that don't necessarily have access to the tertiary, to a caesarean section. Let's take notice of what Aboriginal women are telling us will make a difference to closing the gap on their maternal and perinatal mortality, and let's try it.
So do you know, and this is a follow-up question from Suzanne, what percentage of Indigenous women reject the mainstream health system in remote areas?
In some areas we do. We're doing some research at the moment, and we know that in the 3 largest remote Indigenous communities in Australia, between 5 and 22% of women are birthing in that community, although there's not supposed to be any birthing services. So it's the 3 largest communities, 5 to 22%. A very small percent of those are preterm. Most of the preterm ones actually do get sent out and transferred appropriately. So most of those women, we've got one small research study that's actually showing us that most of those women have actually tried the system already, decided it didn't work for them, and decided to stay in their communities for their second or further babies.
Question from Mika Eltzer, and actually I'm not sure what Mika's talking about, but I'm sure you will. Can you please include the role of doulas in this discusussion? What are doulas?
Support people in labour. Yes. You want to take
Support.
that?
No, you're right.
It's a non-medical support.
So it's a
person.
lay person.
A lay person with who is.
So now my understanding is that from a randomised controlled trial in Dublin, if you actually have a support person with you, you do better in labour.
That's correct.
A trained
A
support.
good randomised trial at the Rotunda in Dublin.
Yep.
And
So this is a very important person.
Look, a support person is absolutely important. And one of the things I'd really like to see is that women that are being transferred from rural and remote areas should actually have a support person go with them. Yeah, paid for, absolutely paid for. If we're going to close the units, let's make sure what we do is going to be an improvement. And that means looking after the kids that get left behind, because that's one of the biggest worries for women, and it means having somebody with them that can be their support person. That's what we're not doing at the moment.
You were looking a bit doubtful when I was talking about a lay person supporting you during pregnancy. You're not a believer.
I've had specific instances which were quite challenging in the presence of a doula in labour, yes.
Right.
But again, that's not statistical.
But that's a semi-professional person rather than just a member of the family? I mean, the Irish study was a member of the family, wasn't it, I think?
Well, I know the Mexico study, which is, they looked at a couple of different things. So one was actually just a woman sitting in the corner of the room that did nothing, and that made a difference. Another was, having a doula or a support person. So we do know that having somebody to support you in labour will make a difference to your outcomes. And we are seeing an increase in some areas of doulas, and I think, it's
So what are you saying, that the doula came in with some ideology and insisting on a certain kind of delivery?
Yeah,
Is that
I
what
think that
happened?
they can become, rather than a support person, can actually have their own agenda, and I think that's a different ballgame.
Right.
Because that's not necessarily in the patient's best interest.
So clearly, Mika, there are doulas
And there are doulas.
This is Anne Flynn, who works in an Aboriginal medical service in Roebourne, Western Australia. My model of care is myself working with a GP, Aboriginal health worker, and 2 women who provide culturally appropriate pregnancy advice, Aboriginal doulas. Our closest hospital delivers only low-risk clients, so we have major issues to provide appropriate pregnancy advice. And so what she's saying is that because of this problem and the disconnect in services, people turn up late, often just in labour, because there's a problem with cultural appropriateness. And a comment from Jennifer Brown, Northern Territory Clinical School, our social worker comments that we need collaborative multidisciplinary models of care, not divisive models, which I think is one of the themes that we're talking about. Just to close the programme, Christine, postnatal care, we were talking about the delivery, and lots of things can happen after the delivery. Depression, difficulties with breastfeeding, hemorrhage. It can be a challenging period.
It can be a very challenging period. I think that in most communities, well-educated GPs are very good at giving postnatal care. They often know the patient very well. They pick up on mood changes very quickly. They often know the families completely. I think where you have an involved GP, it's great. Where you've got a midwife who's followed the woman all the way through, she too has some knowledge of the pre-morbid status and can pick up things that go wrong.
So how long do your midwives follow the women through?
6 weeks.
6 weeks after?
6 weeks, yep. And so
And the
we
baby.
do, yep. Both.
Do they do the well baby check as well?
No, that's done by Child and Youth Health. Yep.
Right.
So Child and Youth Health are still involved, and we work with them.
What do you see, Peter, as a challenge in postnatal care in rural and remote Australia?
I think we need to be careful that we don't save money on the state government's budget by sending women home with their babies, but not provide them with the backup service. And I think that what tends to happen, perhaps we would all be nodding here in agreement, that I think what happens is that the state government has saved money by shortening length of stay, because that's one of their yardsticks to measure the quality of care. Women therefore go home, so they're no longer the state government budget, but they're not necessarily provided with a budgeted service in terms of outpatient midwifery care, and again, the medical practitioners certainly are, but again, we've shifted onto a federal budget there because Medicare bill picks up that tab, or the patient pays for it out of their own pocket in terms of gaps. So I think there's a lot of agenda, again, on the part of the hospitals that are not necessarily looking at the welfare of the women so much as saving
the welfare
dollars.
of their budgets.
And I think
That's
unfortunately
if they're allowed to go home. We now in the Northern Territory have an airline that have actually said that they will not fly babies that are under 7 days old. So women get discharged from hospital and then they're not allowed to go home.
And in a motel with no support. Yes.
A hostel with no support, that's absolutely correct.
It's the best time to fly when they're under 7 days.
Well, you'd
put
think
them on
so,
the breast
wouldn't
and away you go.
I don't know where this came from.
That sounds like a man talking.
We've got lots more questions on our screens, but in fact we are going to have to wind up the programme here. It's been a fantastic programme. Thank you for our satellite broadcast viewers for participating. Thank you for our live call. It's always great to receive one of those. And to close, I'd just like to hear what your take-home messages are for the audience, which is spread between midwives, GPs, procedural GPs, obstetricians, and no doubt there's the odd pharmacist there as well as registered nurses. We just haven't allowed them to poll themselves. Christine?
I think that to enable more birthing to go on in remote and rural Australia, we need a bigger voice. We need the people out there to raise their voice and say, this is what we want, this is what we demand. We want good quality care for our babies in the place that we live.
And presumably, Sue Dunning, your message is if you want that chum, start working together.
Working together, that's right. All professions, multidisciplinary, collaborative, working together.
And you can do it too. How radical you are.
That's right.
Sue?
Innovation, collaboration and strong leadership. I think, you know, that's what, and we're good at innovation in the bush usually, but we need to actually get working on it, talking together and coming up with models that actually suit the context.
Peter?
I'd say succession plans and sustainability are the important things, and because we have a government which I think is interested often in their length of their 3 to 4 years, whatever they're in power for, but we need things that are going to go on for 20 years, because if we don't put them together now, they're going to disappear in the next 5 and we will have problems.
Look, thank you all very much indeed. It's been a great programme. I hope you've enjoyed it too, Birthing in the Bush. If you're interested in obtaining more information about the issues raised, there are a number of resources available on the Rural Health Education Foundation's website, rhef.com.au. Don't forget to complete and send in your evaluation forms and register for CBD points by completing the attendance sheet. I'm Norman Swan. From all of us, bye for now.